Welcome everyone to Precision Medicine Predictions and Pandemic Influence, a panel discussion for the 2020 Medical Innovation Summit. Let me introduce myself. My name is Dr. Hanh, and I'm a physician and the Chief Medical Officer at Healthline Media, America's #1 digital health information brand. Today, we'll take a look at precision medicine predictions and how the COVID-19 pandemic has influenced the current and future landscape of precision medicine. We're really fortunate because we have a truly impressive panel of leaders in genetics and precision medicine. First up is Dr. Charis. Dr. Ng is the chair and founding director of the Genomic Medicine Institute here at Cleveland Clinic. She's also the founding director of the Center for Personalized Genetic Healthcare. We're also joined by Dr. Eric Fung, who is the vice president of clinical development at GRAIL, where he leads several programs working on the development of a blood-based multi-cancer detection test. Also with us is Dr. Robert Nussbaum, who is the Chief Medical Officer of Invitae, bringing genetic testing to the larger market with the goal of making it more affordable and accessible to everyone. And last, but certainly not least, is Dr. Adam Myers, the Chief of Population Health and Director of Community Care at Cleveland Clinic. In his role, Dr. Myers leads services around ambulatory and inpatient care. Welcome everyone, and thank you for joining our discussion today.
Thank you.
Thanks for having us.
So first up, I'd like to ask this question of all of the panelists. Before the COVID-19 pandemic, there was a lot of interest and momentum around genetic testing and precision medicine. Since COVID-19, has that landscape changed individually from your individual perspectives? Dr. Ng?
I will wear two hats, so let me wear my clinical hat first. Since I'm the chief of medical genetics, and genetic testing has to be done in the setting of genetic counseling. And like every other medical specialty, patients physically came to see us. And when COVID-19 struck and shelter at home, nobody could come in to see anybody. We had already since, maybe 2009, had been using the telehealth portal, which we call telegenetics, to our Cleveland Clinic facilities at the Louisville Center in Vegas, and also to some of our more distant sites because geneticists and genetic counselors are in short supply. We shouldn't be driving 2 hours to see our patients. So 2 weeks after COVID-19 struck, all our medical geneticists, all our genetic counselors were able to offer telegenetic services. And so in a sense, we were rushed in the 21st century, and this is how we were able to serve our patients. Certainly, genetic testing became a little bit more in the forefront because on the television, people were hearing, okay, this person got COVID-19, but they just had a little cough and they were fine. The other person died of it. And so one has to extrapolate that certainly precision medicine and genetics has to be brought to bear for COVID-19.
And Dr. Myers, did you see a change in your inpatient as well as outpatient care as well with COVID?
We saw a change in every aspect of healthcare provision as we were performing it. It's no part of our system was left untouched. We saw a transition of less than 2% of our care being virtual to more than 80% in the ambulatory space in just a matter of 10, 15 days. It's now leveled back down to about 40%, and we think it'll probably stay there for a bit. In the inpatient space, we even introduced virtual care there to minimize the amount of contact that we were required to have with COVID positive patients. The simple things like moving ventilator adjustment access to outside of the room so that you could monitor the patient externally and yet still do the things that you needed to do that way. Lots of innovation occurred on the inpatient space as well as the outpatient space for sure.
I'm really impressed at how both of your teams were able to mobilize so quickly within just a matter of weeks.
Yes, and one other thing that we did, which was fascinating, was we had a small group of patients that we were monitoring, maybe about 2,000 or so, using remote monitoring techniques, people with chronic diseases. And that was important to help control their chronic diseases, but it became even more important to take these patients with high likelihood of severe COVID illness, secondary to comorbidities, and keep them home where they might be safer. So we escalated that program from 2,000 patients to 20,000 patients in a matter of about 14 days. And we found that for those patients that were in that monitoring program, they had a 35% reduction compared to controls with hospitalization.
Wow, that's impressive. Now, this is the clinical setting. I think most people knew about that. I'm very curious about the industry setting. Dr. Fung and Dr. Nussbaum, how have you seen that change from where you're coming from? Dr. Fung?
Yes, so in the cancer space, what we saw, particularly during the height of the COVID phenomenon, was really a reduction in people attending their cancer screening. So for example, in the United States, colorectal cancer screening declined by 86% in the first 4 to 6 months of the year. And if we look at some of the studies that have been published over the summer now, we can see that this sort of natural history experiment of reduced screening for cancer is going to actually have a long-term effect in increased diagnosis of cancer and even deaths from cancer. And so this also impacted, and you asked about the industry setting, some of the clinical studies we were working on. And in fact, we're working on a study called Pathfinder with the Cleveland Clinic, and we actually had to halt enrollment during the height of COVID. Fortunately, we have restarted enrollment, but many of the parameters have changed. And so a lot of remote consenting, remote intake of potential participants, remote screening, and that is really part of the process that has been married with telehealth. The other element that I would just point to is that we are also, and especially Cleveland Clinic, has been quite creative in looking at how to have a more distributed patient blood collection approach. And so rather than having everyone come into the medical center to get their blood collected for the clinical study, they can actually do it at a local blood collection center. And this dispersion actually is a very attractive way of moving forward in future clinical studies as we think about how the COVID will actually have long-lasting impact on the way we think about these clinical studies.
Yeah. And Dr. Nussbaum?
Yeah, in the laboratory testing side, I mean, Invitae is an international company. We had already been offering genetic testing services across the country and really across the globe, and had been providing such services for years, relying on being able to obtain DNA samples from saliva or buccal swabs as opposed to blood, using telehealth counseling methods, and also relying on conversational chatbot, something like our genetics information assistant, which allows people to essentially interact with an AI platform to gather information, obtain information, which can then go to the genetic counselor. The major impact on our industry was really on our customers. It's because our customers, and it was very spotty. I mean, there were some, like as we just heard, the Cleveland Clinic was well positioned to continue doing its work despite the impact of the pandemic. Others were caught much more flat-footed. And so there was definitely a hit in terms of the level of counseling and testing that was going on, which is recovering, I would say. But Invitae was well positioned to be able to handle this.
Yeah, I think that's the one clear message that I'm hearing from all of you is that your organizations, your teams were able to mobilize much better than I've heard in other instances, in other organizations. Yeah. I'm curious, do you see that what has happened with COVID is actually going to help accelerate the work that you've been doing with genetic testing and precision medicine, or do you think it'll harm it in the long run?
So, would you like me to address that question? Sure.
Certainly.
Yeah. First of all, I don't think things are going to be the same again in terms of the delivery of healthcare. I also feel that there is still a very strong need for being able to interact with the patient in person, for making diagnoses and for providing care. There's no question about that. But in terms of genetic testing and genetic counseling, a lot can be done remotely. And I can say that many, many patients I have found are very happy with the current situation around genetic testing, that they don't, as Dr. Hanh mentioned, they're not traveling for hours to have a genetic counseling session. It's almost like we're making house calls into their homes using telehealth. And many, many patients enjoy it. And there have been a number of studies showing that the quality of the counseling, customer satisfaction, patient understanding is just as good, if not better, when one uses a chatbot and or telecounseling as an in-person meeting.
can throw some figures into that. So before COVID-19, our no-show rate is anywhere from 15 to 25%, which is about average throughout the clinics, about 29%, I understand. And with telegenetics, telehealth portals, our no-show rate is less than 5%. So people are very satisfied. It's traveling that's the nuisance.
The other thing I might add, if I could, would be from a population health perspective, screening for diseases such as cancer, diabetic retinopathy, all of these different things that are so important for us and are known to be fruitful, oftentimes have been very dependent on a face-to-face visit and very dependent on sometimes pretty involved examinations such as colonoscopy. People have been very hesitant to do those things during this time for a lot of good reasons. And we've been hesitant to open our doors, at least initially, to that end. And as a result, tens of thousands of patients have delayed those screenings, as a colleague from GRAIL described. And those are going to have long-term results. Our hope is that there will be a catch-up time period eventually, but what will have occurred second, what are the implications of the delay associated with that catch-up time? We're finding people now that present with more advanced disease than they likely would have otherwise had they had been availing themselves of greater access and screening. So in my mind, this crisis is accelerating the need for and the attention to alternative ways to screen that aren't as dependent on face-to-face involved examinations, that can be more blood and saliva oriented from a screening device. So that's, from a precision medicine standpoint, one of the keys for this is this adds a real big fire to the platform to move this down the line.
Yeah, I mean, I think it's a nuisance that we have to go for mammography to look at the breast. We have to go to colonoscopy to look at our colon. So this is where I'm going to throw the ball to Dr. Fung to describe his Pathfinder study, where it's just a single blood draw looking at every organ.
Yeah, so thank you, Dr. Engs. And I think, Dr. Myers, you actually used the exact word that I was thinking about, which is access. And today, when we think about cancer screening, we have a sort of a system where we are looking at organs individually, so one by one with a different test for each organ. And the access to the screening methodologies for each of these is quite limited. And they often, as we said, require coming into a medical center. So when we think about multi-cancer early detection in the future, one is that we can look at multiple organs at a single time. And so we're not necessarily doing an individual test for liver cancer and a different test for pancreatic cancer and a different test for gastric cancer. And the second concept of access is that it's a blood draw. And so as we've been working with Cleveland Clinic on the Pathfinder study, Cleveland Clinic took a very novel approach. And instead of requiring everybody to come into their campus downtown, they actually worked with some of the local blood collection centers around the greater Cleveland community. And so potential participants in the Pathfinder study didn't need to drive an hour down into downtown Cleveland to get their blood drawn for the study. And this concept of access, I think, will accelerate, and that will be a long-standing impact of COVID. And so as we think about necessity being the mother of invention, that's clearly one of those characteristics that will be long-lasting.
And as a corollary of that, do you all anticipate that there's going to be more investment, more funding, maybe even perhaps more insurance coverage for precision medicine and genetic testing and counseling moving forward?
I think there will be, and I think for one of the reasons is that one can use genetics to essentially stratify the population to see who's at greater risk and lesser risk. That's either done through looking for individual gene changes and things like BRCA1 or some of the Lynch syndrome genes, or more of the polygenic, multifactorial kinds of screens, so that you can stratify the population, identify that fraction of the population that is a greater prior risk. And therefore, that will increase the precision of any test that you do by reducing the false positive rate. So I think that's going to have a significant impact as well.
Well, I think that's wonderful because I think one of the biggest barriers that we've seen for broad adoption of any new innovation or technology is, as Dr. Eng mentioned at the beginning, accessibility, but cost is the other one. And when we look at those two together, I would love to hear from your insights. What are the mitigation strategies? I know that we're adopting virtual health, but are there other ways? Because virtual health will give you access to the counselors, but are there more counselors available now too to do the genetic counseling?
Yeah, so I think you're looking right at me. Yeah, so unfortunately, there might be anywhere from 600 to 1,600 practicing MD medical geneticists and perhaps 6,000 practicing, I shouldn't even say practicing, I would say genetic counselors registered at the National Society of Genetic Counseling, and some of them are not practicing. And so with this huge demand and a limited supply, we have to think of ways to mitigate. So not driving 2 hours each way to our remote sites is one way. So we have in fact set and used telehealth, including doing physical exams of a cat to our neonatal ICU because it's quite far. And if one of our geneticists is on the west side and they have to drive to the east side, that's not very viable. The other thing is what Dr. Nussbaum sort of snuck in there. It's to use artificial intelligence, and it's called a chatbot, and it's called the Genetic Information Assistant, or GIA. So we actually did a little bit of research with Dr. Nussbaum with Invitae, and we fired off a chatbot for every single person going to colonoscopy to do a quick screen of who's at genetic risk, because with so few genetic counselors, you cannot sit there and take a family history for every single person. And so the chatbot was able to do that. And the pickup rate is about correct, about 13%, which is what we would expect. And, they all came in either to physically see us or see us via telehealth. And maybe Dr. Nussbaum would like to elaborate a little bit more about GIA.
Yeah, so GIA is a conversational, I guess a conversational agent is the official name, but we just call it a chatbot. It's a patient-friendly platform that allows people to interact on their phone, on their smartphones, or on pads, or on their computers, any of the above. And it's a conversation, and it feels very relaxed. It feels very real. It's not like talking to the computer HAL in 2001: A Space Odyssey. It's really.
It's not going to try to murder you.
No, it's not going to try to murder you.
Not asking you if I will dream.
No, it doesn't ask you that. It's very friendly. It's also available in multiple languages, and in some languages now, and many more later. So that's a big obstacle that it can overcome.
Yeah, it's not judgmental, right? It's not judgmental.
Not at all. It just collects information. And I should say that having supervised the counseling clinic for many, many years, genetic counselors are saddled with a lot of what I can only call scut work. Stuff that someone at their level of experience and training should not be having to deal with. And as much as we can eliminate that from using chatbot, using other sorts of tools, we can actually get more out of the counselors that we have, more of what they're really trained to do.
The automation is always very helpful. And other than the chatbot, I'm wondering, are there other forms of automation that are in precision medicine that we're not even aware of? Is there other technologies beyond really being able to risk stratify the individuals?
Yeah, so I sort of snuck in family histories for hundreds of years, right? We have drawn pedigrees and family histories and family trees, and to take it properly does take some time. And so the Cleveland Clinic, I founded a spin-off company called Family Care Path, and that is to automate the taking of family history. So semi-automate. So it's a web-based patient-entered family history tool, and it has risk assessments behind. And in that way, the risk assessment is done for a busy either primary care physician, eventually maybe the patient themselves, and a clinical decision support is pushed into the point of care.
Well, having taken many personal family histories myself, that would be wonderful. A very helpful tool. So we've talked about, oh, sorry, go ahead.
So I might add that as we think about multi-cancer early detection, and particularly that's a novel paradigm of healthcare delivery. And so educating both patients and physicians as to the impact of what multi-cancer early detection looks like. GRAIL is really thinking about and starting to implement different aspects of both physician and patient education and creating portals that are either accessible by the physician or accessible by the patient to satisfy both of these education types of initiatives. And I think that there'll need to be more of those kinds of methodologies whereby we can essentially translate very complex novel concepts to physicians who are obviously highly educated, but maybe experiencing a new way of thinking about cancer detection. And then, of course, our patients who are wondering about how the test result impacts them specifically, both about current risk and potentially future risk. And so we'll be translating some terminology that we physicians use constantly, such as positive predictive value, sensitivity, specificity, and so forth. But we'll need to translate that in a manner that patients understand, so that they really understand what a signal detected result means versus a no signal detected result means. And I think that that's one way where, again, this interface will change quite dramatically.
So we've been speaking very much about the promise of precision medicine and why people would be interested in adopting it. Do you ever see the converse, people who are hesitant or resistant to precision medicine and genetic counseling? And if so, what are the arguments that you usually see? Dr. Myers?
Yeah, I mean, what I've heard from some people is it's a little spooky. They feel like you're going to learn things about me is their information really private? Do I really want to know everything that's discoverable through a genetic testing? There's just the fear of the unknown, I think, that's part of it at times. I'd be interested to hear what other people's thoughts are, but that's what I hear.
Yeah, we hear this, and it's usually all about the education piece, but then it's a catch-22 because the genetic counselors do such a fantastic job. So there's some of the patients who actually come go, why was I hesitant? This is fantastic. But if they're so fearful, they can't even reach the genetic counselors for them to educate them. And so I think Dr. Fung's and the chatbots can have this sort of pre-education enough that they're tantalized and going, oh, it's sort of nothing. And then I can press this button and actually chat with a non-judgmental genetics information assistant.
There's a real red flag in genetic counseling, which is when your patient comes to see you, you talk to your patient and you ask, why are you here? And they say, because my doctor told me to come.
Yeah.
What that means is that this patient is unprepared, really has no idea of why they're there, and therefore could be subject to exactly the fears, Dr. Myers, that you described. Those are precisely the ones. They do not want to talk to a genetic counselor and then have some relative indicted through the use of forensic uses, for example, by law enforcement. Or the other, which is really another big one, the one you described, and that is,
also another
do we want to know this information?
Yeah, do I want to know? I mean, for instance, if I discover I've got this thing and there's no treatment for me, is this a dark cloud that exists over my life in perpetuity until there's something that can be done about it? There's that kind of fear as well.
Yeah, I mean, you want people to make informed consent, informed decisions. So the informed part is step one. That's what Dr. Hanh was talking about. We need to do the education. And then, in terms of finding information for example, a disorder that one might not be treatable, you find everybody all across the spectrum saying, I want to know this because it's going to affect, whether I'm going to retire early or later, how I'm going to organize my life. And then others would say, if there's nothing I can do about it, why would I want to know? As far as I'm concerned, as long as that's an informed decision, it's the right decision.
Well, I definitely have seen that in my own clinical practice, the fear of knowing and wanting to ostrich our heads under the ground. So with that, how do we work collaboratively together to make genetic testing and precision medicine more readily available to others within our society? I think you said education is a big component of it.
And part of the education is to tell people that even over the last 10 years, research has gone exponentially. And for these genetic diseases, and I'm a cancer geneticist, there is very much things that you can do to catch the cancers earlier. Because, of course, when you have a genetic cancer, instead of having a 55-year-old breast cancer, it's a 25-year-old. And so if you know that, screening at 50 is not such a good thing. So we know when to start screening. We know the type of screening, so an MRI instead of your usual mammogram, and we truly are catching cancers early. The next step is prophylaxis. I mean, there's things like tamoxifen and so on. But I would very much like to see a very systematic, targeted therapy trial for our patients with inherited genetic diseases and try to prevent. Prevention trials are very difficult, of course, because the joke is that by the time the prevention trial is done, all of us principal investigators would be dead, and that's not very practical. So the design of the trial has to also change, a sea change.
I have a couple thoughts. What will I think really contribute to the uptake of this and the popularity of this as it grows will be when people realize that they can ultimately get the screening that they need without the inconvenience and discomfort associated with traditional screening methodologies, and that these methods as they're being developed will likely detect things earlier such that lives are saved. I mean, if you have a screening methodology that you can do it with a simple blood draw, either at your home or somewhere else, that can provide reliable early detection and not the inconvenience and discomfort associated with the traditional screening methods, that in and of itself, I think is going to sell. And then that will spread more broadly from normal screening to the evaluation of chronic diseases and things like what Charis were talking about.
I think the other aspect that should not be underemphasized is the virtuous cycle that occurs between genetic testing and the development of therapies that are targeted to specific genetic forms of diseases. I mean, for example, at Invitae, we started a program of testing for pediatric epilepsies, and it started a fairly narrow band of patients for whom a new therapy had been developed. And it was a small percentage of those patients was for type 2 Batten disease. That has now exploded. A pediatric neurologist a few years ago would have said, what's the point of doing genetic testing? We're just going to try a bunch of anticonvulsants. Now there's specific therapies for particular forms, and the genetic information helps guide therapy. So it's a complete sea change. So therapy driving testing, and testing then helping the therapies.
Dr. Nussbaum, you're great at mind reading too, because that was going to be my next question. Yeah. We've been talking a lot about oncology applications. What are other applications of precision medicine and genetic testing? I think a lot of us have heard about oncology, but is it being applied to other condition areas like cardiology or even COVID-19 itself?
So cardiology for sure. Probably the first one that really hit the scene is the ability to treat cardiac amyloidosis and to treat amyloidosis in general. There are now specific treatments for both the TTR mutant form as well as the wild type form of amyloidosis. So using genetic testing to help guide therapy for amyloidosis is a major step forward. There are also now some therapies that have developed for cardiomyopathies. There's been for years now, actually, an underutilized and underappreciated value of determining whether people are at risk for long QT syndrome, or particularly for possibly fatal arrhythmia, either in terms of drug selection or avoiding certain drugs, or introducing better monitoring and preventive methods. So it's certainly happening in cardiology. I can tell you that we are being inundated, we at Invitae are being inundated with companies that are developing novel treatments, precision treatments for neurological disease, in particular neurodegenerative disorders. The next 5 years is going to show an explosion in Parkinson's, in ALS, and in Alzheimer's dementias that we did not have before, that are based on genetically determined forms of this disorder, of these disorders. So I think it's only going to grow.
Yes, I think there's
we know that germline P10 mutations, I discovered that as predisposing to breast, thyroid, and other cancers. We also discovered about 15 years ago that it also causes autism spectrum disorder. I mean, who knew? And while it supposedly causes a rare heritable cancer, PTEN mutations are one of the most common causes of autism. One of the targeted therapies used in cancer is called mTOR inhibitors. We just closed an mTOR inhibitor trial for children with autism and PTEN mutations. And so you'd say that I will pick this for kids with autism and PTEN mutations, but it won't work for kids with autism and another mutation or no mutation. And so then let me just slip in pharmacogenomics. And this is where Dr. Myers will come in. Pharmacogenomics is the genetic alterations, usually in genes, that produce drug metabolizing enzymes. And different of us have different variations, and we metabolize drugs at different points. So this is now suddenly genetic testing for everyone. So let's have Dr. Myers will speak to the population.
Yeah, thank you, Dr. Hanh. As you're aware, many patients don't just suffer from one specific problem. And they might have diabetes, hypertension, hyperlipidemia, and depression. And so they might find themselves on a variety of different medications, and sometimes medications to treat the side effects from medications. And all of these things can interact with each other in ways that can limit their utility. And I mean, we've all probably treated patients who were frail and elderly who came in not doing very well. And one of the first things I would do with patients like that is what I call pharmacologic debridement, where I just progressively start stopping one medication at a time or several at a time and go, I don't know what's going to happen, but we're going to see. And then they start to wake up, and it's amazing. Well, a lot of that interplay between things and the side effects from the side effects could be prevented if we understand how people metabolize medications more clearly. And that's where pharmacogenomics comes in. It does help delineate for us, not at this point that in every situation, this is exactly the medication for this person. But what it does do is it can help us understand these are medications to avoid with this person, or because of potential problems, or they just won't be as effective for this patient. And that's better than what we started with, which was sort of the hunt and peck method of picking medications. But ultimately, we'll get down the line, I hope, in the future to where what you were describing with the different types of PTEN mutation versus no PTEN mutation, or different forms of childhood epilepsy that respond to discrete medications, that we can get to where for common diseases such as hypertension, diabetes, the ones that we've described, that we could do a test and know specifically which medication is going to be most effective for a given patient. But we're getting there. It's a work in progress, but that's how it's fruitful to a significant degree so far from a pharmacogenetic standpoint.
That impacts COVID-19 treatment as well, probably more so than ever. So one of my faculty members, Dr. Fei-Sung Cheng, he uses systems biology, so big data from every single form. And within 2 weeks after the COVID-19 pandemic hit, he was able to use it and show that FDA-approved drugs can be repurposed for COVID-19.
Well, I feel like you're already going to know this one and be able to answer it very easily. One last question for our panelists. What do you think is next on the horizon for precision medicine? We'll start with Dr. Fung.
Yes, so we're going to be really utilizing novel ways to give greater access to patients all across the country and around the world, and be less tied to actual physical presence at a major medical center. And this increase in access will be enabled by several factors, one of which is, of course, as we were saying, different kinds of ways to diagnose disease through blood tests. And then it'll be the interaction between information obtained from these sort of simpler ways of getting information with natural language processing, medical records, with types of the chat boxes that we've talked about on this call, that will allow the conveyance of information in a very directed and personalized manner. And that will lead to an iterative effect of more precise treatment and hopefully better outcomes for individuals.
That sounds wonderful. And Dr. Nussbaum?
Yeah, I would just like to echo Dr. Fung's comments and just add one other. And that is, I think the shift is going to be more towards proactive genetic testing and proactive assessment rather than always reacting to a problem that's already there. And then that will feed in to being able to not only get information from the EMR, but use the EMR as a real platform for physicians to be able to deliver precision care. We need much, much better clinical support systems to be able to deliver precision medicine.
Indeed. Dr. Myers.
Yeah, the only thing I would add at this point would be, I think it'll ultimately make care more affordable. And here's what I mean. Right now in healthcare writ large in society, we have very finite resources to apply to this, but infinite perceived needs. So we've always have a series of prioritization of where are we going to apply our resources. And so many of our resources now do get applied to treatments that may or may not be truly effective for individuals. If we can find a way to be more discrete and more specific with our treatments based on being informed by genetics, then we will be able to not be wasting those resources inappropriately, and then can redirect the resources that would have just been ineffective toward more effective care for those patients, and then spread that to treating others as well. So ultimately, while it is expensive on the front end, ultimately, I believe this is going to help make care more affordable and more available for a broader swath of our population.
Great point. And Dr. Ng, close us out.
I've always shown this picture of the elephant and the wise man, where they go, precision medicine is this skinny rope, right? Feeling the trunk, it's this wall. I think, which means that we are using genomics, so the tip of the iceberg, to base precision medicine on. And we've forgotten the other 5 parts, meaning the transcriptome, the methylome, which the GRAIL Pathfinder study just begins to address, the proteome, all the proteins, the metabolome, all the metabolites, and the microbiome, which are the bacteria, viruses, and fungi that live in and on us, and we know it affects it. I would like to use all of these ohms integrated to come down to a single individual, risk stratify, and either have preventive precision care for that individual in a very proactive manner. Now, our traditional funding mechanism, so research is the basis for everything, is we fund projects, but we don't fund infrastructure. It is now vital that we have to fund infrastructure for both research and clinical care, or we will always be reactive. We want to be proactive. That's what precision medicine is.
Well, you all bring wonderful points. Thank you so much, panelists, for your time and insights. That was a wonderful discussion. And thank you, everyone out there, for joining us for this enlightening Medical Innovation Summit discussion brought to you by the Cleveland Clinic.
Thank you.
Thank you.
Thank you for having us. Thanks very much.